Thank you. So we visited the community and we saw how people live. Also, we talked to them about what their daily lives look like. Um, our aim to do this was because we were going to set up camps from Monday through to Wednesday to talk to them about non-communicable disease, especially diabetes and hypertension. So our aim for the first 2 days was essentially to see how people live in the community and what kind of diet and lifestyle they lead, for us to be able to talk to them about their
So,
lifestyle.
so once you set up a camp for example,
Mhm.
diabetes, so what do you intend to do there?
Yep. So for the camps that we set up from Monday through Wednesday, our aim was essentially to have like a little checkup for them. So we took their blood pressure and we also took their random blood sugar levels. It was random because most of them had teas or biscuits already, and then we also took their height and weight for their BMIs. And essentially, this was because of how the trends of heart diseases are rising in India, especially. Through these camps, we also talk to them about the awareness of hypertension and diabetes, of why Indians are so prone to getting hypertension and
So why are the
diabetes.
Indians so prone to getting hypertension?
So I think there's two factors to this. One is a genetic component, which
Mm-hmm.
we all have, and we cannot modify that. And then the other component that we have is a lifestyle component.
Mm-hmm.
Our lifestyle, especially, I would say, not so much in rural, but a lot in urban areas, it's getting sedimentary, and we're not walking around as much. We're not exercising as much,
Mm-hmm.
and our diet is very much primarily based on carbohydrates and very much based on very high GI foods, which is also very similar to how people eat in rural areas. So we, in through our camps, we also did some counseling about talking to them about what a healthy diet looks like and what they should eat.
So, okay, I have a question for all of you. So, the diet that we have been using now is the diet we have been using for last 100 years,
Mhm.
before even that. What has changed in the last 50 years that we are seeing an uprise in diabetes or hypertension then? The diet had stayed the same, more or less.
More or less, diet has stayed the same. You are correct. I think in the last 50 years, there's another, I would say there's two components of this. I would say the traditional diet has remained the same, but in the younger generation, there's a lot of junk food and a lot of processed food consumption that has increased. And if you see any packet of the processed food consumption, there's high in salts, high in sugar, which is of course bad for your body. The
Agreed.
other component
Agreed.
is,
Agreed. Just make it more conversant.
yep, the other
So the
component,
younger people are in the age group of 0 to 30.
yeah.
The ones whom you think are using these junk food, processed food,
Yeah.
right? How many of these children that you met in your community
Mm-hmm.
posting did you find hypertensive or diabetic?
There were a few, we haven't compiled the data yet,
Mm-hmm.
but there were a few young adults who had high blood pressure. Now, we cannot diagnose them with
Right,
hypertension by just
right.
one
Now most
reading.
of these you find in our villages, young diabetics. They are generally lean. They don't have obesity,
Mm.
so they are not the ones who have picked diabetes because of the fact that they have been using diet which is high in calories. There are some other reasons for that.
Yep.
So my point is, do we are we able to link diabetes and hypertension to diets or obesity in younger age? Yes or no?
Can you repeat the
Because
question? Sorry.
my point is, it generally takes a generation
Mm-hmm.
of people. It will take us around 30 years for a population who are subsisting on a diet which is high on calories, which is high on junk food, to actually translate into an epidemic of hypertension and diabetes.
Mm-hmm.
So we have not had yet 30 years of this junk food in our population.
Mm-hmm.
Our population has been using junk food maybe for last 20, 25 years. So the actual pandemic of it may pan out in years to come. The ones who are suffering because of diabetes and hypertension at this point in time, between ages of 30 to 60 to 70, are the ones who may not have used junk food for a large part of their life. So that's
Yeah.
what my question.
Can I say something?
Yes, just I'm brainstorming. I'm not giving you the answers.
You said that in the past 100 years, the diet hasn't changed, but somehow diabetes and hypertension has increased so much. It might not be that it's actually increased. It might just be that people are testing now. Yeah. So now you know that these people are actually diabetic and hypertensive. So many people, we go to the villages, we take their histories, we ask them about their family history. Oh, did your mom or dad have anything? Did your grandfather, grandmother on any side have anything? They all say, nah, nothing used to happen in those days. Back then, everyone was fantastic. They just weren't tested. it was likely that they probably did have hypertension, they probably did have diabetes because of their diet or because of their
Okay.
lifestyle.
Okay.
But
So
they didn't know.
this is an interesting conversation that most of the time students come up with. Now, do we have a historical aspect of how hypertension or diabetes has unfolded in countries like India or across the world? We do have. We have a theory of epidemiological transition that has unfolded across the world. And as far as India is concerned, we have a historicity of hypertension and diabetes. The earliest studies in India on hypertension were conducted as far back as 1940s. So do we have the prevalence estimates for that? We do have. So those prevalence estimates tell you that hypertension was much, much lower than what it is now. So we were picking them up at that point in time. We were trying to pick them up. We didn't find it as commonly as you find them now. In our part of, if we look at this part of the world, in Himachal Pradesh, some of the earliest studies on hypertension came in year 1980, 82, 83. So it's roughly 40 years back. And what was the prevalence of hypertension at that point in time? 2%, 1%. So it's not that we were not picking them up earlier. It's just that we are actually seeing a rise in hypertension and diabetes. So picking up and saying that we didn't have enough of data available earlier may not be the correct way of putting it out. The earliest studies for India on hypertension have come up from places like Chandigarh, from Kanpur, which were very urbanized at that point in time. Kanpur was much more urbanized than rest of India, even in the 40s. If you may not be aware of it, Kanpur was the first place wherein a large-scale industry was set up in the textile, and it was called the Manchester of the East because of the fact that it had huge amounts of textile industry. So it did see industrialization in the earlier part of the last century, but still we didn't pick up huge amount of hypertension from these places. So there is something else that has changed in last 60, 70 years.
I think that is the other part that I was trying to say, which was the lack of exercise and the increased of the change of primary profession in India. If you go back to how the percentages of what people used to do back then, majority of our country was farmers, and that has now changed to us preferring going to urban cities and doing more sedimentary jobs such as in offices and those things.
Chronobiology.
Yes, so when you decrease the exercise and the use you're getting out of your body essentially, and not really changing your diet, which is your high GI foods and which essentially gives you energy, you will see a rise in hypertension and diabetes, and that's
So I
correspond to the
agree with
timeline.
this, that we have seen a high GI food, abundance of high GI food in India in last roughly 60 years now. We have seen a high abundance of high GI foods, but that's not probably linked to the amount of junk food or those high salty or sweetened foods that we are using at this point in time, because as I said, it will take years for us to unfold the epidemic because of that. Why we are using this high, what's happened in last 60 years is that our food that we consume has changed in its GI because of the type of food that we are using. So maybe before the 60s, when we didn't have that green revolution setting in India, if you look at the epidemiological transition, if you look the way diseases have unfolded in the West and the diseases have unfolded in India, it's slightly different. West saw a more slowly progressing epidemic of non-communicable diseases. It started from roughly 1930s and transitioned into 1960s, 70s, 80s, and then there was a blow up. Oh, we are seeing certainly a spurt of diabetics and hypertensives in the West. We didn't see it in the 30s and the 40s. We saw it around the 60s, when certainly we had a concept which is known as green revolution, wherein we had food which was high in yield. So the earlier foods that we used to have, for the rice or the millets or the wheat that we used to have in India was low in yield. It was of a different variety. Then the combination came and we had a high yield variants of food. Now, what did these high yield variants of food do? They became the glycemic index, the high glycemic index foods that we have been having. Also, once we have a high yielding food, the prices of the food dropped down, and it became easily available to everybody around us. And rice and wheat were easy to manufacture in terms of yield. They were easy to grow as compared to a food like millets, for example, maize, for example. So it not just introduced those high glycemic index foods like wheat and rice, it also removed coarser foods from our diet. It removed the millets, it removed the maize, it removed the locally available foods from which we would make our staple diet. So it removed those. And we largely moved to a two food system. Either we would be wheat eaters or we will be rice eaters. And between the two, if you look, the rice was one which picked up faster. In particularly in the Indo-Gangetic plains. Indo-Gangetic plains is if you start from this place, you go down to Uttar Pradesh, Bihar, Punjab, Haryana, places wherein there was richer sources of water, underground water. We call them high fires. So these are the places wherein the water was in abundance. So you could grow these high yield variants rapidly, and rice was easy to do. But rice has lower amounts of protein if you compare it to wheat, but it has higher amounts of carbohydrates. It has a higher glycemic index. And at the same point in time, the milling came, the concepts of industrialization came, so you removed the fiber content of these foods. So that's how it unfolded. And to it was added the 1990s industrialization revolution, the fact that we became a software technology driven country. So we had more sitting jobs, urbanization helped us with transportation, so that also came into play. So most of these things combined. So it was not just because of the fact that we saw an abundance of food which was packaged, which was much later, which came into our lives much later, around the 2000s. Before that, we didn't have that. So actual ramifications of that food, the packaged food, adding to what we are already doing, may be unfolded in next 10 years, and we will see a much larger and worsening picture as far as diabetes or hypertension is concerned in this country. So that's how we see it. So when you talk of combining it with community, generally when we do it the way you said it, is the way we do it in our postings in community medicine. So I will talk about that with some bit of detail, because we will talk about other things as well. If we have the presentation here. No, yeah. So it's beautiful campus. If you get time, do visit some of the places if you are around here in the day. So you may see these beautiful mountains. These are the Doladars wherein you are sitting at this point in time, right? And this is the building where you are at currently. This is the building you are currently. This is the one you are in. So before I need to tell you something about the subject per se, because as I said, you people are not familiar with the word community medicine. Community medicine is something which is not taught in your subject. So generally we say that in India, we generally divide the whole area of medicine into three simple disciplines. We can segregate it into public health. We can second pillar, or the vertical pillar, can be community medicine, and the third vertical pillar could be hospital medicine. Right, within the hospital medicine, you will have the surgery, the medicine, the emergency medicine, and other subjects. Internal medicine, for example. And then you have a clear public health branch which needs to deal with the public health issues. And then there we have the community medicine, which is somewhat juxtaposed between the public health and the internal medicine. When we were talking about that non-communicable disease concept, I said that the driver for the primary driver for a rise in non-communicable diseases may be the high-yielding variants of food that came into our life in the 1960s, plus the fact that we saw a lot of improvement in transportation, urbanization. And these may be the primary drivers that took us to what we are in now in terms of diabetes and hypertension. But how many of you in person, as an individual, are able to prevent that, stop that, change that? As medical professionals, can you change urbanization? Can you stop urbanization? As medical professionals, can you change or stop high-yielding food variants that came into our life? You won't be able to change. That job is primarily left to the people who deal with public health. So public health people will deal with that part of it. They will make policies that have large-scale implications, connotations for what happens in the domain of medicine and community medicine. Clear? So that's what we say. This is public health. So public health may not actually be restricted to people who deal in medicine. A large number of people from different occupations can be a part of public health. So even a lawyer can be a part of public health as a domain. So a lawyer who is espousing the cause of better road traffic conditions is actually pursuing public health. A journalist who raises issues with regard to your road traffic issues or with regard to the sanitation problem in your areas is doing public health. I hope I'm clear with that. So why does community medicine come? Now we talk about that because that's the fundamental area which I wanted to talk, and because that will answer some of the questions that you people were wanting to raise. Now, this is how exactly a student follows community medicine in our department, is expected to follow. To be very honest, it's very difficult to actually translate this idea into how exactly a student should be following community medicine. But this is the core principle on which a community medicine student should be which a community medicine student should be following over his postings in the department over a period of 3 years. So the student enters into community medicine in first year, like you people who are in the first year. So they will enter in first year. They will stay with us in the second year. They stay with us in the third year. At the end of the third year, we have an examination for them. Actually 3.5 years. So at the end of 3.5 years, we have an examination for them in community medicine. Then they enter into the medicine and surgery, then they have their examinations there. So the student enters with us on the first year, and this is the integrated community-based learning framework. So we have, what we are trying to do, we have a few disciplines which are in a way not naturally aligned or not naturally integrated, but exist in silos. But the aim of posting in community medicine is to integrate them somehow, is to find an integrated meaning of all those which are there as existing pillars. So every student follows one continuous narrative. I have specifically used this term narrative. And every student is expected to follow the narrative which begins from family, not from individual. So which begins from family, goes to an individual, then to community, then to systems, then to disease prevention, management of disease, and policy impact. So community medicine student in his 3 years posting is actually needs to go through all these phases. He needs to move from family to policy impact. So this is the ideal way a community medicine posting should happen in medical colleges across country. So why this is done? This is done to avoid fragmented learning. So that's what I said. If you go to a community is diverse. It doesn't have a structure which can be boxed into anything. It doesn't actually follow the rules of means and the medians. It's spread out. So you have to follow the community as it is, whether it is fragmented, united, disjointed, whatever way it is. So you have to approach them in a way wherein those fragments are connected through what we call as community health portfolio development. So this is something that we want our students to come up with at the end of their posting. They have a community health portfolio which integrates all of what they have learned. So once the student come to us, they come to us in the first year, 27th probably, next Saturday students will come to us for their family posting. So we have roughly 120 students in each batch, and each of them will be allotted 3 families. So roughly we will have 360 families covered. So at this point in time, we are picking up a village which is nearer to us. If you have traveled from that side, that side, then it comes between Yol and this place. This is a place called Serathana. Each student will be allotted 3 families and prepare the following templates. This is the thing that they have to do once they are given these families. So they will have the demography and socioeconomic status, something that you talked about. So they will have an awareness about the number of people that live in that family, the distribution of the family, the young ones, the elder ones, the adults, how exactly they are distributed, and what's the socioeconomic status, what's their level of education, what's their level of income, what's their level of, what type of occupation they are included in. We also look at the housing and the environmental conditions. So we look at the build of the house, whether this house is actually conducive to healthy living, or there are some issues with the house itself which may not be good for the healthy living itself. We look at the nutritional patterns of the family. We look at water, sanitation, hygiene. We look at occupational exposures if there are any. For example, somebody is working in food industry, somebody is working in furniture industry, manufacturing industry within that family. If there is anybody, we need to look at that. Then we look at vulnerable members. So there are, within the demographic hierarchy, we have identified over a period of time vulnerable populations. It's the same across the world. So you have an elderly person who is supposed to be vulnerable. You have an under 5 pregnant women, chronic disease patients. So they all have to be identified within this family health profile. And then findings from the investigation, this is something that we have done. So most of the people, as you people may have visited these families, so a lot of these people whom you visited may have been investigated already. They may have been investigated for diabetes or hypertension because of the fact that, as you said, you have a high number of diabetics and hypertensives in your population. So somebody may have been investigated already. So if they have been investigated, we register those investigations within that portfolio, family health profile. If investigations have not been done, we do them during our postings in the families. So we do random blood sugar, as you did. We do hemoglobin estimation. We do hypertension measurement. We do anthropometric measurements. We do urine. We look for proteins in urine as well. So these are the things that these students do on their own while they are posted in the family. So these are the investigations that they will have to list as part of their family profile. If they have been done, they will be listed. If they have not been done, what we do, that has to be listed. Clear? So that's part of their first posting. So this is something that we are trying to incorporate now. This has not been there, but this is something that we are building now. Family disease vulnerability scoring. Now, doing it as you did it, you went there, did the random blood sugar estimation, did this hypertension measurements, did anthropometry. But what we want from student is to derive some interpretation which is meaningful once they leave out of that family. So once they leave the family, they have something which is meaningful in terms of interpretation. So what are the environmental risks that are there in that family? So we are thinking of building an environmental risk score within that family. So are there anything which are environmentally non-healthy, unfriendlier, which will be leading to occurrence of disease or mishap and injury and accident within that family? We need to list that. So we will broadly build a score on that. We need to have a behavioral risk score within that family. So are there any behaviors, use of alcohol, use of smoke? Are there any behaviors within the family which will predispose them to a disease in their future life? So we will be thinking of building a behavioral risk score. We already have these patterns which are not within the subject at this point in time, but we will be using it from other areas and build that score from there. Nutritional score, whether the nutrition that they are using or the diet they are consuming, whether that is actually translating into the nutritional health that we are interested in, yes or no, that will do. NCD risk score, this is something that you people talked about, that NCD was one area. So we are thinking of using WHO package of essential non-communicable disease interventions from primary health care perspectives or criteria. Now, if you look at the way system is panned out in India, we said we have public health, we have the community medicine, and we have the hospital medicine. But if you look at, this is one way of doing it. The other way of doing is we have the primary healthcare system, wherein we have the sub-health centers, the sub-centers that you visited. We have the primary health centers, which are at the level of the blocks. We have which are below the level of the blocks. We have the community health centers, which are at the level of blocks, and then we have the district hospitals or sub-district hospitals, which sit above that of the community health centers. So at the base level of health, if you are looking at health facility, the base level of health is provided by the sub-health centers. And the job of sub-health centers is actually to provide promotive and preventive health care. They are not supposed to actually deal with curative care. Curative care is something which should essentially come into healthcare delivery at the level of primary health centers only. So at the sub-health center level, we deal with preventive and promotive care. At the PHC level, we do deal with preventive and promotive care as well as curative part. And then above it, we always deal with both the preventive as well as curative care. The PHC is generally managed by a medical officer. The sub-health centers are now being managed by the community health officers, which we have been recruiting for the past 5 years. And these community health officers are actually nurse practitioners the way they are in your place. They are nurse practitioners, have been trained for a period of 6 months in delivery of non-communicable disease, prevention and treatment. So they are the ones who deal with at the level of sub-center. So sub-center, PHC, CHCs, sub-district hospitals or district hospitals, and then we have the tertiary care hospitals, which is this institution, the medical colleges or the medical schools. Clear? So the aim is, when we are looking at the village level or when we are looking at the posting in community medicine, we want them to evaluate, treat, manage, interpret non-communicable diseases as per the condition wherein they are posted at that point in time. So because they are posted in the village, they are posted at the level of a PHC or a sub-health center, we want them to use the primary healthcare criteria. We don't want them to use secondary or tertiary healthcare criteria. So what I mean by that is, they need to interpret the disease, understanding, management should be focused on what's available locally and what can be given locally, not what can be given 60 kilometers away from them, 100 kilometers away from them. I hope that's clear. If we have a headache in a family, the headache needs to be managed the way it will be managed at the level of primary care, not at the way it will be managed at the level of tertiary care. The difference between the Indian Indian healthcare delivery and the West is that while the West follows more of a referral chain system for its patients, we don't follow a referral chain system for patients in India. So if you have a headache patient in India, he doesn't need to go to primary care. He can straight away go to a neurologist, a tertiary care set of patients. He doesn't have to necessarily follow the path of primary care to tertiary care, right? If you go to my OPDs in the neurology at this point in time, a good number of patients will be simple headaches. So to sort of circumvent that or balance that, what we want is that the patients in the primary care are managed, treated the way they will be in the setup, that setup only. We also need to understand communicable disease exposure score. So we once they go to the families, we need to understand whether the family per se, the environment per se, predisposes them to a communicable disease. For example, whether there are any mosquitoes around that may predispose them to malaria, or whether there are any the waterborne infections which are around them which may lead to any waterborne infection within that area. So this is something that we need to assess on the basis of environment and provide a communicable disease exposure score. Then, as I said, investigations which have already been done or listed there, or those which we do, will be listed that as a part of a score also. So somebody whose blood sugar is raised, you will say that this patient is a patient of diabetes and has a chance of picking up complication in terms of macrovascular complications, microvascular complications. This is a score that will fit that particular patient. So what's the outcome? Outcome is students predict risks, later validate with actual cases, and learn epidemiology in real life. So what we are trying to do is that at this point in time, there's a disconnect because of the fact that the student doesn't go to the individual cases or patients at this point in time. He is just placed in the family, has a larger background and understanding of the family per se, on the basis of which he has built some risk scores. He has not seen the actual patients at this point in time. I hope that's clear. Now what we do is in module 2 is we develop these individual case studies. So we will ask them after their posting in in their postings in the families, once they were allotted, they go back, spend their time in physiology, anatomy and biochemistry, pass physiology, anatomy and biochemistry, come back to us in the second year, and once they come back to us in the second year, we ask them to do this along with something else, but we ask them to look at cases. So what are the cases that we want them to look at is a healthy adolescent or an adult. So even a healthy adolescent or adult needs to be investigated, healthy elderly needs to be investigated, diseases like diabetes, hypertension, TB, etc. need to be investigated. Under 5 children, again because of the fact that they are vulnerable, they need to be investigated. Antenatal and postnatal case needs to be investigated. And what they learn is again risk assessment, screening tools, behavior modification. This is all listed over here. So this is something that we'll need to learn, but each case is tied back to the family determinants. So you see the case now, you see a case of hypertension, and you go back and connect it to what was there as part of the risk score that you had identified for this family. So you had listed that this family has a higher nutritional risk score in terms of picking up diabetes and hypertension, and now you are actually seeing a patient of diabetes and hypertension in that family. So that linkages have to be established. Higher risk score in first year, and then availability of a patient of diabetes or hypertension in that family in the second year, that linkage has to be identified, and that's the basic aim. So then we also send them as part of module 3 we also send them within that second year. Within that second year, we also send them for public health system interface. So while we ask them to do families in first year, in second year we ask them to look at the cases as well as do this public health system interface that you people have done already done. So students map the family's health needs to relevant public health infrastructure. So as I said, the delivery of or the assessment of diabetes, hypertension has to be facility specific. Those facilities have to be identified. So the village that we send them, we also ask them to map the facilities which are available there. So is there a sub-center there? Is there a PHC there? Is there a CHC there? Is there a district hospital within that area? Yes or no? That's something that we ask them to do. Which services the family actually uses. Now this is something interesting. As I said, somebody who falls sick, picks up a disease in a village, and India doesn't necessarily need to visit a sub-center PHC or a CHC within that area. He can straight away run into a medical college and gets himself treated. So we need to understand whether these families who are living in a particular area are utilizing the services that are there in the sub-center PHC or CHC. If they are not utilizing, what are the gaps? Why are not they utilizing? And how these can be circumvented or these can be modified. For example, I have done a simple gap analysis. Family has hypertensive patients. The nearest PHC doesn't have ECG or biochemistry analyzer, or statins are not available there, so the patients are referred. Ideally, everybody will like to be treated as near as possible to him if the facilities are available. So for example, you want to investigate somebody for diabetes or hypertension, you need a biochemistry analyzer because it's not possible to do it manually now. So is the biochemistry analyzer available in the government setup at this point in time in that PHC? Yes or no? If it is available, then why the patient is not reaching there, approaching that, that's a separate issue. But at this point in time, if biochemistry analyzer is not there, the patient may always choose a facility wherein this is available to them. Right. So we also send them for field visit activities such as sub-center. Sub-center, when we send them to sub-center, we ask them to look at antenatal checkups, immunization, PHC, OPD, NCD clinics, milk plant, meat center, we want them to look at food safety, water treatment plant, again environmental health. They must map each visit to how does this system affect my allotted family. So that's where I continue to say the emphasis has to be on, if this gap analysis, they have done a gap analysis, how does it actually influence the family? How does it impact the family? It may impact the family in terms of rising out-of-pocket expenditure. And once the out-of-pocket expenditure increases, the chances of a person seeking healthcare drops down. So it will influence actually the health-seeking behavior if the out-of-pocket expenditure increases. So this is something that they need to do. The students need to come up with us that look, because of the fact that the health facilities are not able to provide this, they need to travel 60 kilometers, 80 kilometers they need to travel. And because of the fact that they need to travel, the out-of-pocket expenditure increases. They don't follow the advice of the doctor regularly. They don't go for follow-up checkups. They don't monitor their blood sugar regularly. So that's something that the student monitors. Not just that, there are acute events that happen within families. For example, there is a snake bite in the family. The ideal way of dealing with a snake bite is within a period of 6 hours. So we need to shift that patient as early as possible. So whether my PHC has a doctor who is able to deliver snake bite envenomation, is able to take care of the patient through anti-snake venom or not. So that is something that these students need to come up with. They need to tell us that also. So this converts field visits from sightseeing and applied learning. This is this is something that my postgraduate yesterday spoke to me. So she told me that once we send the students for them, it's an excellent opportunity. And because of her, I went and saw some of my students who were posting YouTube videos on their channels. And one of my students had posted a fascinating video on her first posting in community medicine. What I wanted from my student was she would tell me what did she actually see in her antenatal checkup posting at the sub-center. What did she see in a sub-center? But I was surprised in that 8-minute video, 7.5 minutes were devoted to the bus ride that they were having to that particular facility. Out of those 7.5 minutes, 1 minute was dedicated exclusively to the dance that they did in the bus. 30 seconds would have been specifically spent on the facility itself. Out of those 30 seconds, 25 seconds were spent on what did they eat at that place. And 5 seconds that I saw was wherein they panned the camera to one of my postgraduates talking to one of the students in one of the corners of that health facility. So 8 minutes wasted. But if you send those 8-minute video to somebody, the idea that student or anybody who is looking at the video gets it, that it is a very good place to go for a picnic. Community medicine posting is a paid picnic for the students in a medical school. So that's something that I wanted to avoid. So we need to convert these sightseeing field visits into applied learning. So this is the module 4 that I want them to come up with, so which is disease treatment and perspective. So now they come to us again in the 3rd year. So they come to us in the 1st year, family allotment. 2nd year, we ask them to pick up cases. We give them the field visits, and then they come to us in the 3rd year before going into the exams. It's a 1-month posting. So what do we ask them to do? Identify, diagnose or potential disease in the family. We ask them to identify the patients, come up with these patients to us. So their patients could be hypertension, diabetes, COPD, anything of this sort. And on these patients, develop a mini management plan. So they have to have a plan for these patients. So one of the commonest thing that I ask my students is, if they see a patient of diabetes in a family, so they should come up with a diet chart plan for that particular patient. If they have not done that, it's an incomplete thing that they have done in the family. If they have a hypertensive, if they have a hyperuricemia in the patient, they need to come up with a plan for that. So develop a mini management plan for each, which will include clinical features, investigations, treatment management as per standard guidelines, follow-up plan and preventive measures that you talked about. Why you chose God? Because of the fact that they use preventive measures. This is something that we ask our students to do in their posting. Then there is this important thing that I want to build in now. To be very honest, we have not built in at this point in time, but I want them to use community level prevention linkages. I will talk of this in detail when we talk of next. So module 5 is family community situation analysis. So this is something that I want my students to do. So what I said was that there are roughly 360 families allotted to me now. It's a huge number. 360 roughly translated into 1,000 people. And if you look at Western countries, 1,000 people is a big number. If you tell them you have 1,000 people at your hand, they will say, oh, this number is too huge for them. So now you have these 1,000 people with you, and 1,000 people under your one batch. So what we want the students to know is they need to come to us with prevalence of hypertension, for example. So 1,000 people, all of them get together, these 120 students. They say, I have a patient of hypertension, she has a patient of hypertension, this person has a patient of hypertension. So roughly there are 100 patients of hypertension within those 360 families. So we can give a prevalence of the hypertension for that particular area wherein they are posted at this point in time. Similarly, prevalence of diabetes, because we do blood sugar measurements, as I said. Anemia, because we do hemoglobin estimation, as I said. Under 5 malnutrition, because we do the measurements. We do the measurements of under 5 children. So we can have that. Immunization coverage, because again we cover that part as a part of our posting. Antenatal care indicators, we do that. As I said, antenatal case is a part of us. BMI distribution, how exactly is body mass index distributed around these 1,000 people? Water sources and sanitation profile, what's the condition of this? If you have 1,000 number has a good power in terms of analysis to give you good data. And these people have 1,000 people at their disposal, minimum 1,000 people at their disposal. What is the outcome? What's the rationale behind this? Students learn community diagnosis, epidemiology and biostatistics using their own data. At this point in time, we teach them about biostatistics, that this is mean, mode, median. Now they have the data with them. They will have an understanding of biostatistics and epidemiology panning out live, real life in their families, and that can be translated to us when we examine them. This is the last, the module 6 community action presentation. This is something that I talked about in earlier also. So now you have the whole gamut of it. You have an understanding that hypertension is high. You have an idea of the fact that nutrition is a risk factor, behavior is a risk factor. Can we plan a community action plan? Can we make a community action plan which is distributed around the village, build it as a part of our intervention? So hand washing demonstration, for example, salt reduction campaigns. Go to these villages, go to these families, organize a meeting of everybody who resides in the family, particularly the females in the family who carry the message better than males. So make them sit and talk to them about how to reduce salt in the intake in the family. Growth chart awareness for the mother. So we have the 1,000 data of 1,000 people roughly. Out of those 1,400 will be children to us. Have the data on them. Give it to the public there. Give it to the mothers there. Look how your children are behaving in terms of growth. Can we make an amends in that? Hypertension follow-up reminders. Can we develop that? Now your patient has been identified with hypertension. You have 100 hypertensives in the family. They need to be treated on a regular basis. Can we place some reminders through our WhatsApp messaging, through some digital media intervention, so that is sent to them on a regular basis and they take up that follow-up. So this is not for you people. This is how faculty can evaluate. This is a simple rubric that I have created for the faculty to evaluate how these students can be evaluated on that. Thank you. This is again one of the pictures of the institution. If you have any questions, comments, you can ask me. I will be more than happy to answer.
Is this the program that you're running for the 3-year program? Is that only in Tanda, or is that like a countrywide thing?
The countrywide thing is that we need to have their posting for 3.5 years in community medicine. That's there. But over a period of time, different institutions use this 3.5 year differently. We in our institution are trying to make it more outcome based, more objective as compared to other places. So that's the idea behind us. So this is a framework that we have developed for our students. It's not universally followed across the institutions in the country. This is for our students only.
And how long has this program been running?
Now, the fundamentals of this have been there for last 2-3 years, but this is something that I am trying to build in now at the level that I am showing you now. I told you the reason for this was yesterday's conversation with Dr. Ruchi. She talked about the videos and I saw the video, and that I had to spend half of my night on making this.
No, like you described the whole program, and I think we'll all agree that it's a very comprehensive program, and overall, like it not only benefits the community but like the student in many ways. And I personally really enjoyed listening to that and knowing that this can be a potential program that will be running in India. And I would be curious to know like what you find and what results students come up with. If you have any from the last 2-3 years, I would be more than happy to listen to those.
We have been collecting the data for the initial part of it. So for example, we have the family adoption program, which we have already been running for the last 3 years now. We have the data coming from that, and we are in the process of publishing the data on that. I think Swati has made the data on that. We have an idea of how exactly diseases are spread or panned out in our population. In terms of the data sets that I talked about, because we do have a large number of we have a big population available with us. So we have some idea on that. We have an idea of what's the prevalence of diabetes, hypertension, what's the prevalence of anemia in these families. That data is available with us. So and that data is going into publication very soon. But we have not the data on how exactly to build integrated systems with defined outcomes and measurable objectives. We don't have that at this point in time. That's something that I want to build in.
Do you think that the data that you will be collecting and what you already have can also be used to influence some policy making around this?
This is a wrong question to ask from a wrong person. Once the disease reaches a level wherein it is more common than uncommon, the likelihood of that disease being found in the hospitals, in a select population, and in the general population outside the hospital is almost the same. So the number of hypertensives that I will see in a select population in a hospital and the number of hypertensives that I see in a general population while I do a study is almost the same. So the policy is influenced only when you are coming up with something which is different through your innovation intervention.
For example, I also mean to say, as when you were saying that the sub centers and PHCs, the primary health centers, can handle a lot of the diabetics and hypertensive patients if they have the right equipment or the people actually go to those. But through the students, when they will go and visit the communities, they'll find if these centers actually have those equipments or the biochemical analyzers as they are needed for the management of these conditions. For example, say the students do find that a lot of these PHCs or the sub-centers do not have these machines or the equipments that we need to manage these conditions. Would Is there a way to get those equipment in those centers so that the burden on the tertiary hospitals is reduced, because these patients can easily be managed close to their home, so better for the patients and also better for the doctors at the tertiary centers?
This subset of data is obviously useful on that. We do have, if you look at this place, District Kangra, we have some places wherein these facilities are available. We have some places wherein these facilities may not be available. So it's not uniformly distributed, and it may also depend upon the footfall in each of the facility, the PHC levels wherein you do have. Fortunately, at this point in time, most of these PHCs are connected to autoanalyzers, not directly. They are connected to autoanalyzers or investigations indirectly. So even if the machine is not available at the PHC level at this point in time, but patients who come for investigation, their samples are collected and they are transported by a system which is in a public-private mode stage at this point. So they do come with their investigation, they can get investigated, but the investigation part is not done at the PHC level at that point, this time. Samples are transported to a place like our place, samples are transported to a place like some at a secondary level place wherein they are investigated, the reports are sent back to the PHC. So there is a thing in place which doesn't actually translate in a sense that an autoanalyzer is placed in the facility, but it works in more or less like a hub and spoke model, wherein we have a hub wherein the autoanalyzer is placed, other machines are placed which look at the investigations, and these PHCs and CHCs work as the hubs for that. Samples are spokes for that. Samples are transported to this place, and then the investigations are done. This is an implementable model. So if you are telling the government that look, or if you are telling the people look, the number of investigations that will happen in a PHC is 100 per day, they will obviously want to shift an autoanalyzer machine there. That's not a big issue with this. So this subset of data will be useful in doing that, in shifting the hubs more closer to the spokes,
Yeah.
and not letting it stay at one place only. So that will be helpful at some point in time.
Thank you.
Anything else?
Didn't start
TB?
TB
Huh.
and also about HIV and AIDS. So are you involved in that in any way, or do you have any comment about how to get past the stigma that it actually get to treating the patients? Because we saw that was a bit of an issue.
Actually, I'm involved with a few ways in TB. I see TB at different levels actually, and the problem with TB is that the understanding of TB is restricted in a way. I would like to use this word restricted in a way that we have not been able to understand the entire epidemiological profile of TB. It's not a problem with us in India only, it's a problem with the West as well. They don't understand TB as well. For them, TB is still an enigma. And for us, TB has a limited understanding because most of the things that come about TB or that are talked about TB are born from the West itself. But their understanding is poor about TB. So while we have rolled out a program on TB, the National TB Elimination Program is there in place. It does hundreds of things. It doesn't do one single thing, including the fact that you talked about how to take care of stigma, get the community involved, get to the grassroots, get the villages involved, directly talk to the community, get them involved. I still see a lot of stigma in it. And the problem is that the stigma is something which doesn't go away with a program which is as loud as TB is. TB is a very loud program, loud in a sense that it is talked about every day, almost every day in India. TB is not something which is not talked about. People talk about it. Health policy makers talk about it. Even the top level leadership of the country talks about TB. And that in itself is something which doesn't actually encourage people to come up with the fact that, look, we want to be diagnosed with TB. That's one part of the story. The second part of the story is there is an impression about TB that TB is a disease of the vulnerables. It's a disease of those who sit on the fringes of the mainstream, in a sense that they have immune compromised, are poor, do have a disease. TB is not actually a disease of those. TB is much more widely spread across populations. So it's not just that a young kid may pick up TB, or a very elderly patient may pick up TB, a diabetic may pick up TB, HIV patient may pick up TB. They will pick up, but others will also pick up TB. And once you have a population wherein you say that roughly 30 to 35, 40% of people have been infected with tuberculosis at some point in time, so your chances of having a disregard for the disease is natural to come up. So we ourselves say that 40% of us have been infected with tuberculosis. So what's the likelihood of me regarding it as something significant, something serious, something which I need to address immediately? It's like if you have a batch of 100 students and I tell them eventually 40 of you will fail. So you have a higher chance that the students who are not wanting to study will say, okay, we may eventually fall in that 40, let's not work hard enough. So that's the story of TB. Unless and until we build an understanding of TB which is more scientifically oriented, in a sense, I would say. TB is not actually a disease which is limited to immune compromise. It's not a disease which is limited to comorbidities. TB is a pure airborne infection. It is I call it air as the social determinant of disease, social determinant of TB. So unless and until you take care of that air that is around us, you don't address it as one of the basic fundamental drivers of TB, we are not going to address TB. So that's the primary thing about TB. So maybe we need to shift from making TB an individual specific disease. An individual needs to pick up for the disease, he needs to be investigated, we need to do an X-ray, we need to do a sputum analysis, and then on the basis of, say, this is a TB positive, now we need to put this patient on presumptive treatment or something like that. We need to say, look, this area is wherein we live, this area has a higher chance of delivering TB to its inhabitants. So for example, this room has a higher ability to deliver TB to those who sit in this room. This school, this has a higher ability to deliver TB to its students. This prison, this has a higher ability to deliver TB to its inmates. So if we are able to shift that burden, shift that conversation from individuals to the community, to the collective, our chances of fighting the stigma associated with TB are higher. But it's unlikely to happen at this point in time, as I said, because of the fact that most of the conversation on TB is derived from what the West taught us, and the West has very poor understanding of TB. HIV is something which we do much better, despite the fact that it has stigma associated with it. But HIV, we have some fundamental strengths which prevents us from picking up HIV as compared to the West or other places in the world, and that fundamental strengths do help us as far as tackling HIV is concerned. TB is slightly different as compared to HIV.
We were talking to Narendraji at CORD before coming here, and he was mentioning that you also have interest in unpolitics, and to ask you about it. So I just want to ask you about your take on unpolitics.
Now, unpolitics, basically, we started an organization in 2020, post-COVID. We started an organization, World Health Network. And World Health Network is an organization which is comprised of roughly 150, 160 people, scientists from different fields. So some of them are environmental, some of them are chemists, some of them are engineers. So they came together, and the idea was to fight COVID. The idea at that point in time, 2020, was to fight COVID. So we initially started with COVID Action Group. So COVID Action Group was the first organization that we which we formed in 2020. And most of the people were from the West, but we had participation from the East as well as from African continent as well. So we had a few participants from there, but most were based in Europe or US. Some were from Australia. We had one, Rana McIntyre is from Australia, and another name, there were 2-3 people who were from Australia also. So we began with the COVID Action Group. That COVID Action Group morphed into World Health Network, and World Health Network is a big organization now. It received people from all across the world, different types of people, different domains of people. And once we built that World Health Network, it had some verticals in it. So one of the verticals that we thought of was building societies, because individually it was not possible to fight what's happening around us in terms of disease and health conditions. We need to build societies. So one of the societies we thought of building was Unpolitics. The aim of Unpolitics at that point in time was to fight what's wrong with science. So our understanding was, which I speak to my postgraduates also, our understanding was that the science which we need to be doing and the understanding of which we need to have is not the science that we are practicing at this point in time. So that was a belief with which we started. We wanted to see the role of science in being able to deliver, not in being able to discover. So that was the motive behind it. Discovery is fine, but if you are not able to implement that discovery, if you are not able to use that discovery, it doesn't have a meaning. If your science doesn't reach out to the last mile, if it doesn't reach out to the last person in the society, your science has no meaning. You can do anything with science. You can make models of science, but if it doesn't reach out to the people who are to benefit from science, your science is wrong. I always tell them that for me, science was finding fire. Science was finding a wheel. Science was not something that we did on bench, came out with, doesn't have a meaning. So that was the idea with which we started Unpolitics. And the other idea behind Unpolitics was to fight anything that is based on anti-science. And we call anti-science as something which is primarily opinionated, which is primarily based out of opinion. My opinion is this, your opinion is this, and because it's my opinion, so it becomes science. We have been fighting over a period of time now anything that comes in the form of systematic reviews, which comes in the form of meta-analysis, which comes in the form of opinions. I personally believe, as well as people in the Unpolitics believe, that systematic reviews and meta-analysis are an exaggerated view of opinionated pieces. So opinions become exaggerated and become systematic reviews and meta-analysis. The basic principle behind that was that most of the systematic reviews and meta-analysis collate the data which is already available. So if the data from which you collate your systematic review and meta-analysis is wrong, doesn't have a meaning, has been collected wrongly, your systematic analysis exaggerates the wrong that is there in individual studies. So that was the basic for that. We also thought about, when we are talking about Unpolitics, we also thought of picking up the outliers. So if you have done any amount of research in your days in medical school, we talk about the mean, the medians, the standard errors, the standard deviation, the p-values, we talk about that. So in Unpolitics, we said that's fine. You have to have reproducibility. You have to have science which is reproducible, science which is generalizable, which has to cover most of the population. But we also need to take care of the outliers. We give an example in Unpolitics that, for example, I have to reach an airport. My airport is, you all may have come through that airport, Gaggal Airport. If you have to land in an airport, generally they say that your flight is plus minus 5 standard deviation 1:30 p.m. So the flight reaches 1:30 p.m. plus minus 5 standard deviation. So they say it may come around 1:25 and they come around 1:35. And you plan your visits within that standard deviation. So you plan, okay, so since the standard deviation is 1:25 to 1:35, if I go around 1:35, that is absolutely fine with me. But if a flight comes at 1:25, you are going to miss the flight. Got my point or not? The flight timing is 1:30 mean, but the standard deviation is 25 to 35. And you have to reach the airport on time. The time is 1:30. The mean time is 1:30. But since you believe the standard deviation, since you believe the statistics, you say, even if I go at on 1:35, that falls within the standard deviation of the arrival of the flight. But imagine the flight comes at around 1:25. You are missing the flight because of the fact that you believed the means and the standard deviations. So science is like that. What you miss in terms of means and standard deviations may be very, very critical. So unless and until we incorporate that critical component in our science, we are not doing something significant, something we did with COVID-19. Our understanding of science never gave us an inkling of COVID-19. Did it give? It will not give us an idea about the new pandemic unless and until we start picking up these things. We start picking up these abnormals, the outliers, which are not there within that standard deviation and means. So at Unpolitics, we also try to build that insight because of the fact that we invite diverse group of people whose idea of things are different from my idea of things. So I may be very good at health, but somebody who is very good at understanding of environment, somebody who is very good at understanding of water and sanitation, somebody who is very good at understanding of buildings itself. So we gather them together and want to gain an insight into what might strike us in future, what may be important to us future. I always give an example. The best thing to learn medicine from, the best people to learn medicine from is not from people who practice medicine. The best way to learn medicine is from those people who practice or dabble in stock markets. So they have a better understanding of things that may be critical, that may change rapidly, that may have an influence on our bearings that will be crucial to us, right? So the best way to analyze something which is crucial is to look at the stock markets. How do they pick up the change in the stock markets? They will see, look, the markets are going up, sell off the things. Markets are falling down, hold on to your things. So that's something which is very critical to them. We in medicine are not able to pick up that criticality. They are very good with that. So Unpolitics does that only. And as part of Unpolitics, we have had first meeting in July, which was attended by 100 people across the world. We are going to have another one in February, in the end of February, 24th to 29th of February. And it will be attended by, it's expected to be attended by around 500 people. There are some rapid talks that we do. We don't do traditional talks that I did like this because I know the attention span for you people is now much smaller than it was in my age at my point in time. So we do rapid talks there. So we have a 5-minute talk is delivered. The best of the people deliver in that. So you don't have that ego that I'm a big man, so give me 20 minutes to talk. Even the biggest of people talk within that 5-minute time only. So we have those rapid talks of 5 minutes. Then we have group meetings. And this year we are building in group meetings around workshops. One of the workshops that we are planning is on tuberculosis only. So we are building those group meetings around workshops only. So we will have a group of people who will try to deliberate on where did we go wrong in terms of not being able to implement something, and what are the solutions to do that? What are the solutions to rectify that? So finding solutions is one of the core principles of Unpolitics.
Why did you decide to name it Unpolitics?
I was a part of the core meeting which decided it. And why Unpolitics? Because we wanted to differentiate, or we wanted to take it away from politics. We wanted to keep it as far as away from politics as possible. And the only way to putting it away from politics, as far as away from politics, was finding a word which was entirely opposite to politics. We didn't have a word at that point in time. We just sat together, some of us, we were brainstorming at that point in time, and we thought. And the people who were sitting at that, I was the only person who was from health. There were people who are in the security domain, not health security domain, who are in the domain of security in terms of country security domain. So they were there. Then there's a friend of mine who was a physicist from MIT. So they all sat together and thought, let's find a name for it. And we came up with Unpolitics. The only reason was to stay away from politics.
You mentioned that in this Unpolitics, you also there's a team who deals with all the new meta-analysis that's coming up, and you want to tackle the things that are opinion based rather than the objective based. So how is that done? Like,
we don't actually deal with that. We don't deal with meta-analysis, but we discourage reading into meta-analysis. So or framing policies on the basis of meta-analysis only. We discourage that. We don't do meta-analysis. Some of the people who are part of the unpolitics group are people who have grown out of meta-analysis into being against meta-analysis. I am one of them, but there are others also who have grown out of that domain of doing meta-analysis and now say that meta-analysis have a problem. So we don't do meta-analysis, we don't target meta-analysis. We say that the problem with meta-analysis is that it's not core fundamental science. It's not that. I give an example, I probably wrote about it also. If you go to PubMed at this point in time, PubMed if you go to the PubMed at this point in time, and if you look at last 25, 35 years of PubMed, and if you look at the number of original papers that have been published on PubMed and the number of meta-analysis and systematic review that have been published in PubMed, you will see there has been a huge jump in meta-analysis and systematic review and a huge fall, equally proportionate fall in original research. Because meta-analysis and systematic review are easy to do. They are easier to do. Original research is difficult to do. So you find there has been a jump of roughly 35%. There has been a jump of, if you look at the numbers, 35% of the research is meta-analysis now. There is a jump of around 1,500 times in last 35 years in meta-analysis. And most of the meta-analysis is not actually contextual in terms of the fact that it is not current. What meta-analysis captures is what has been happening for last 10 years, 15 years, so it's not current compared to an original research that is done now. And a lot of meta-analysis comes from on genetic research, which is also outdated.
So acknowledging the issues that you mentioned, when we learn about research, we learn about the hierarchy of how not how valuable, how reliable paper is, and then we rate RCT, systematic review, and meta-analysis on the top of that pyramid, and we are also taught that these are the ones that you should use for the policy making and for any decisions that you want to make because they are more reliable. Looking at or acknowledging the issues that you mentioned, what should we do in terms of in terms of the policy making, or us as future doctors, when we want to make some decisions for our patients? And should we look at the RCTs, or like as someone who's not heavily involved in research, what can we do?
Now, I wrote a paper I shared with them also a few days back only. What I usually ask patients, I usually ask from clinicians or those who are practicing in dealing with patients to have an idea of what's there in research in terms of what's there in an RCT, what's there available in an RCT, or what's there available in a systematic review, but not to be influenced by it.
Okay.
An individual case doesn't reflect the cumulative effect that an RCT or a systematic review or a meta-analysis is giving you. It's entirely different. I give an example. I usually give an example like this. The best of what has come to us in terms of research is come from, not from meta-analysis. It's not come from systematic review. It's not come from RCTs. The best of what has come to us in terms of research has come from observational studies.
How to define
I talk about it. I will detail that.
Sure.
So if you look at what we learned from, for example, thalidomide. Thalidomide was never an RCT. Thalidomide, the impact of thalidomide, the effect of thalidomide was simply based on certain cases, 3-4 cases, and we learned that thalidomide phocomelia. So we learned of the adverse effects of thalidomide from 3-4 cases. We didn't do an RCT, we didn't do a systematic review, meta-analysis to learn of that. We learn of anosmia in COVID, for example, from one single case. We thought, now this is abnormal. This is not something which is known, which is normal. So every case who comes to you may or may not follow what is there in the RCT, what is there in the what's there in the systematic review or meta-analysis. Every case may actually give you different perspectives which are not there. What makes a case important? Look, if the case falls in the central domain, it falls in the RCT domain, it falls in the meta-analysis domain, it falls in the systematic review domain, then it won't be a problem. Right? So it won't be a problem, you will be able to tackle it very easily. But if it doesn't follow in that domain, it will be a problem. You won't be able to tackle it and the patient may die because your RCTs don't answer that, because your RCTs were not able to pick up that outlier. Most of what we do as part of RCTs or even later on systematic review is based on a sample. So I say, let's have 100 patients. So 100 patients, 50 go here, 50 go there. Not exactly 50 go, randomly here and there. But that 100 patient distribution is assumptive in nature. That's based on an assumption. And that assumption tells me that if 100 is a good number, and if 100 is the number that I am incorporating in my RCT, it will give me a good understanding of how patient will respond to a drug. But is 100 the number that you are dealing in actual life?
No.
You will deal with thousands of patients in actual life. I tell them an example. I give them an example. You watch cricket. Australia and India are very, very fond of cricket, you know? So India has been losing toss for last 26 times. Probably they won last time, 27 times they won the toss. They have been continuously losing toss for 26 times. Now, will your RCT, systematic review, meta-analysis, sample distribution pick that loss? What is the probability of somebody continuously losing 27 times in general population? What's the probability as per your sample size estimation? What's the probability for that to happen? Very, very low. It's one in a billion, even lesser than that. We say, even if your basic statistics tells you that if you toss your coin 20 times, 5 times there is a chance that it will come, at least one time it should come the other way, 19 times it can go other way. But so imagine 27 times it has gone one way only. So what's the chance? 1 in a billion.
Yeah, 127.
So the important thing is that in your clinical practice, you will always and always be worried about those things which are not there in the middle domain. They will only be those which are there at the periphery. So if you restrict your understanding of medicine to that middle domain, you are likely to lose that criticality that is there in the peripheral domains. I usually tend to give this example. What's the minimum amount of time a drug needs to be studied for having an understanding of its implication on human body? What's the minimum years of a drug needs to be studied? We put somebody under an RCT for a drug. What's the minimum number of years that we need to cover to understand the exact impact of the drug?
I don't know, it's a guess. Huh? It's a guess, but like 15 years.
15 years. Anybody else? 30, 40 years. So at least we need to cover it for one full generation. So somebody who has been given one drug now needs to be followed for one full generation to see how exactly kids have responded to it. The kids born from a mother who has taken a drug, when they grow up, so they are now 30 years of age. Now, how exactly it has panned out? How many RCTs do that? So the fact is that because we generally tend to use a small frame of time, a small number of people, and then base our RCTs or studies on that basis, doesn't actually reflect truly in the population. I don't say don't do that. I always say do that. But you need to, when you are collecting data, when you are collecting data on an RCT, when you are collecting data on a study based on a sample, you should also look at what's lying outside what is available with you. So there may be, out of 100 patients that you have seen for a particular drug, you say 50 or 60 or 70% of patients show this result, 10 show this result, 5 show abnormal results. And what does your statistics tell you? What does your statistics tell you? When those 5 show entirely abnormal results, what does your statistics tell you? These are outliers. Rule them out. They don't make, they have no meaning. But actually these outliers may be the ones that are giving you an insight into the future. So picking up those outliers is very, very important. What RCTs don't do, they don't pick up those outliers. Not just RCTs, most of the studies don't pick up those outliers. The idea is to capture the middle path, no doubt about fact, have reproducibility, because that makes science easy. If I don't have the middle path, if I don't have reproducibility, I would not make, science will become difficult. But when you are doing science, you also need to identify the outliers, because they are the ones which will give you some actual insight into the future. I call it the known uncertainty and the unknown uncertainty. The known uncertainty is the risk that you talk about. The unknown uncertainty is something that you need to know about. If you are able to know about that unknown uncertainty, your chances of avoiding COVID were higher. Your chances of avoiding Ebola was higher. Your chances of avoiding HIV was higher. Your chances of avoiding TB was higher. Your chances of avoiding an accident on a daily basis is higher if you are knowing the unknown uncertainty. Right? You give me a known uncertainty that 1 out of 10 people will meet with an accident today, for example. That's the way we do our statistics. So 1 out of 10 may have an accident today while you are reaching from one place to another. But does it tell me who out of these 10 will have that accident? If I don't have an idea of who out of these 10 will have an accident, I'm not giving anything significant to that person who is being influenced by that research. So picking up that unknown uncertainty is as important as picking up known uncertainty. So that's why I say, I wrote a paper on this, you talked about. Very recently, it was published 5-10 days back. Hierarchies don't make science great, does it? Exactly, this was titled like that only. This was my second paper confronting the hierarchies.
So essentially, you're saying that we should pick the model for our research based on what we want to, what study we want, like what or outcome we want, rather than the hierarchy of the.
I don't say it like that. I don't say that research should be based on outcomes or should be based on what I want to obtain.
No, sorry. What I mean was it depends on the research question. Is essentially, for example, if we are comparing a new drug to an old one that already exists, I would say probably like a randomized control trial would be good, but also doing like a cohort study or following some patients.
No. What I say is that if you are trying to address a research question wherein you are pitting one drug against another drug, and the standard process of doing that is an RCT. That's absolutely fine. I don't have any issues with that. Do an RCT. But once you are analyzing the results of an RCT, keep a provision for inclusion of something which was found abnormal in it, which was being ruled out as an outlier at some point in time. So don't rule out outliers. Include them as a part of an analysis. I ask a question, you people, I don't know how many of you have done RCT or have read about RCTs. How many negative RCTs have you seen?
Not many.
Not many, you have not seen any. If you have seen, show me one, which has been published in NAGM, which has been published in Lancet, which has been published in Nature, that this is a negative RCT. You don't find them.
There's a file, like a file drawer effect they call it, where they just shelf them because they don't want to publish them.
Exactly. So why do you want to? The fact is that these negative RCTs would have been a good idea about what went wrong. Unless and until your policies, your programs, your studies don't have a built-in caveat for failure, you're not doing science. The failure is a part of doing correct science. If you are not building that in, that means you are opinionated. You are not doing science.
Well, yeah, I mean, a lot of the time it's for like money's sake. Like with depression medication, when they actually did a study, I think it was in like the National Journal of like British Medicine. They did like an analysis of all of the drugs used to treat depression, and when they saw all of like RCTs that weren't published, I think the effect of tricyclics, the effect of SSRIs was like 50%. It was like garbage.
Yes.
But if you like Google it, Google AI is going to tell you like, oh, it's 80%, it's 90%. But that's just file drawer effect. But that's like because they want to make money. Someone's going to buy your SSRI if it's not like proven to be effective.
So that's the other part of the story, the conflict of interest in conflict of interest in RCTs. RCTs have a huge amount of conflict of interest. But if you look at RCTs, for example, there was probably the sprint trial, which talked about cholesterol. Within 2 years of time, it was withdrawn because of the fact that they realized that this was not working the way it was supposed to work. Fortunately, they withdrew it. Otherwise, most of the people at that point in time were blaming the exogenous cholesterol on raising endogenous cholesterol. They were not thinking of what's happening within the metabolic pathway of liver and other things. So it's good, you do science, but you also need to incorporate the entire analysis that is there as a part of your science. You don't pick and choose your analysis. When I was doing, I have of late, the last 4 or 5, not more than that, 10 years almost, I have not done statistics. I used to do statistics in my early career as a postgraduate, then as a senior resident and a faculty man. And I will tell my juniors at that point in time, the results that you are obtaining through statistics in one way can be entirely changed to the other way if you are using the statistics differently. So the way you do statistics on a particular study, once you decide the effect size, once you do the sample size, I say, okay, let's keep the allowable error at 10%. So we are changing the game, changing the goalpost. Let's keep the allowable error at 5%. Let's keep the allowable error at 20%. Let's keep the effect size at 80. Let's keep the margin of error at this place. Let's see that a jump of 2 degrees, if the blood pressure falls by 2 degrees, we say this is a useful thing. So these things are decided by us only. Once you do a study, we decide it. We decide this is the way it will happen. And if it happens this way, then our hypothesis is proved right. So that's how we do most of the studies. So that's the problem with the studies per se. So the unpolitics part addresses that. We try to look at that more in a more scientific way. Anything else? That's good.